Our next category of drugs we're going to discuss are calcium channel blockers. Calcium channel blockers are another antihypertensive medication that we commonly use, and they've been around for a very long time. If you remember when we talked about the anti-anginal drugs, we use calcium channel blockers to relax the muscles of the vascular walls. And so when we decrease that smooth muscle tone, in other words, relax the muscle walls, we get vasodilation. So the pipes of our vasculature opens up. And when we open that up, the vascular resistance decreases, right? So if you have a tiny pipe that you're putting fluid through, the pressure's high. If you have a big pipe, you have decreased systemic vascular resistance, and therefore you get decreased blood pressure. And what these drugs do is they block the calcium channels so that smooth muscles have to relax, and that's how they work. So we have a few different types of calcium channel blockers, and some work on the heart and some work just on the blood vessels, so on the heart and on the blood vessels. Your exemplar drugs are the diltiazem, amlodipine, and nifedipine. There's really three different types of calcium channel blockers. I don't expect you to know the three different types, but the reason that we divide them is because some work on the blood vessels and some on the heart, some just on the blood vessels and some just on the heart. But just suffice it to say that these are the calcium channel blockers that you should know. So, why do we use calcium channel blockers? We use them, as we discussed in an earlier lecture, to deal with angina. If we decrease the blood systemic vascular resistance of the blood vessels, then we decrease the work of the heart, we decrease oxygen demand, and angina can be resolved. We use them in hypertension. If you increase vasodilation, in other words, decrease systemic vascular resistance, you get lower blood pressure. So we use it for hypertension. Remember, we talked about how calcium channel blockers can also calm heart rhythms, and so we use them for dysrhythmias. One thing that we don't use them for ever, for the most part, is heart failure. So they're contraindicated in heart failure, and we'll have addressed that in our heart failure lecture too. So, what are the adverse effects of calcium channel blockers? Well, it's all those things that would occur if your blood pressure went too low. So, hypotension, we talked about. Also, because it deals with heart rhythms, we can get palpitations and tachycardia. Another actually kind of big adverse effect of calcium channel blockers is constipation and nausea. So I would be tuned into that if you have a patient that's on a calcium channel blocker. Our next set of medications we're going to talk about are vasodilators. So vasodilators are just medications that directly relax the arterial or venous smooth muscles. So vasodilators do the same thing that calcium channel blockers do, really. They decrease systemic vascular resistance, and by doing that they decrease afterload, and they cause basically peripheral vasodilation, and that's why we call them vasodilators. Vasodilators are exemplar drug is hydralazine. We're also going to talk about sodium nitroprusside, but our exemplar drug is hydralazine. So why do we use hydralazine or vasodilators? We use them to treat hypertension, which is what our lecture is about today. It can be used again in combination with other medications. I think an important thing for you to know also is in the case of hypertensive emergencies, our drug of choice is sodium nitroprusside, also called Nipride. Why do we give it? How do we give it in emergencies? We give it IV. Why do we give it that way? Well, because it's the fastest way to get the drug into the system. So the drug of choice for hypertensive crisis or hypertensive emergencies is sodium nitroprusside. Hydralazine has some side effects like dizziness, headache, those types of things that would be something you'd see when someone had blood pressure that was too low. And this works the same for the sodium nitroprusside or nipride. Okay, so our next category of drugs is going to be the adrenergic drugs. So let's review, go back to our sympathetic nervous system and mainly the autonomic nervous system. We have the parasympathetic nervous system, which is our cholinergic system, stimulates smooth muscle, cardiac muscles, and glands. And then we also have our sympathetic nervous system, which is the adrenergic system that stimulates our heart muscles. That's the fight or flight, and it causes vasoconstriction. And this is just a graphic to show how that works if you need a review on that. Okay, so really the adrenergic drugs have 5 subcategories, and this is, I know, can be a little confusing, but bear with me here, or you can re-listen to this slide set and hopefully it'll help them. There are the ones where they're centrally acting and peripherally acting adrenergic neuron blockers. So we have centrally acting alpha receptor agonists. Okay, so we think about the alpha receptors. These are centrally acting, meaning that they act in the brain and they make the alpha receptors work. So they cause you would think that they would cause vasoconstriction, but they actually cause you think they'd cause vasodilation, but they actually cause vasoconstriction. I know that's confusing. Peripherally acting alpha 1 receptor blockers, peripherally acting beta receptor blockers, and peripherally acting dual alpha and beta. So we're most familiar with the beta blockers and the peripherally acting beta and alpha receptor blockers. But let's talk a little bit about all of those. Okay, so let's talk about the centrally acting alpha 2 receptor agonists. So the centrally acting means they act in the brain. Alpha 2 means that they typically, with an alpha 2 receptor, you get peripheral constriction, and an agonist means that it causes peripheral constriction. So all that you're going to have straight in your brain, and then I'm going to tell you what they do, and it's going to be the complete opposite of that. So these centrally acting alpha 2 receptor agonists stimulate alpha adrenergic receptors in the brain, just as I mentioned before. They decrease the sympathetic outflow, meaning that they decrease sympathetic stimulation, they decrease norepinephrine production, and they stimulate alpha 2 adrenergic receptors, which you would think might cause vasoconstriction, but what it does is it actually causes vasodilation because it's a negative feedback loop that's very complicated to explain. But one thing you do know from looking at the renin-angiotensin mechanism is that it reduces the renin activity of the kidneys, and by doing that we decrease vasoconstriction, which causes vasodilation. So suffice it to say that these adrenergic drugs that are alpha 2 receptor agonists still cause a result in blood pressure, and that's the important take-home message there. What are the drugs that we use like this? Clonidine is one, and so is methyl-dopa. They typically come as patches, as you can see in the example here. So, same drugs, the centrally acting alpha 2 receptor agonists. We use them to treat hypertension. We usually use them after other drugs have failed. So what other drugs are we talking about? We're talking about the diuretics, the ACE inhibitors, the ARBs, the calcium channel blockers. These are our next go-to medication when other drugs fail. And these are just some other reasons we can use them. How does it work? We talked a little bit about that. They're peripheral alpha 1 beta agonists. I'm sorry, the next category of medications, which is our peripheral, not central, but peripheral alpha blockers or antagonists. This blocks the alpha receptor, and that is doxazosin and terazosin. And these result in decreased blood pressure. Why do we use these? Obviously to treat hypertension. And there's other reasons too, but I won't go into the detail. We just need to know that we use these to treat hypertension. Okay, so then our next category of medications that you're familiar with from our anti-anginal lecture and from the hypertension or heart failure lecture is the beta blockers. So beta blockers act in our periphery. They reduce blood pressure by reducing heart rate, right? By blocking the beta 1 receptor site, beta blocker. So beta 1 receptor increases heart rate, increases cardiac output if it's stimulated. If it's blocked, it decreases heart rate, decreases cardiac output. It can also cause a decreased secretion of renin, gives long-term peripheral vascular resistance reduction, and the medications we use are often propranolol, atenolol, those all drugs. Our newest one is nebivolol or biastolic. Anyway, the point is it decreases blood pressure. And this is just an example of how it works. Adrenergic drugs, the dual acting, so this means we get not only a beta effect but an alpha effect as well, are drugs like carvedilol. It does both. And again, we get decreased blood pressure. These dual acting adrenergic blockers act in the periphery, on the blood vessels, and in the heart, and they reduce heart rate as well as cause vasodilation. So that's why we like them. Labetalol is our exemplar drug for this. So all the adrenergic drugs, whether they're an alpha agonist or a beta antagonist or blocker, can cause high incidence of orthostatic hypotension. So it's a balancing game, right? You're trying to treat their hypertension, but you don't want their blood pressure to be too low. So all those symptoms that might be associated with that, we can see at times. When we talk about managing high blood pressure, I want to jump to well, actually, JNC 8, I think, is just now out. It took forever to come out, but the 4 stages of blood pressure management and to be aware of what those cut points and guidelines are. I think you get that in your med-surg class. This is just a slide from your text, but we know that we really want the blood pressure to be less than 120 systolic and less than 80 diastolic. And we really can't be satisfied with anything that's less than that. If we can't, people shouldn't walk around with a blood pressure of 140 and 100 over, to 160 and think that that's okay because we know it causes long-term damage. So why are we aggressive about managing hypertension? Because when someone's hypertension, it puts them at very high risk for heart failure, for high cardiovascular risks like stroke and death. We treat people post-MI with these medications to make sure their blood pressure is low. It can prevent kidney disease, prevent stroke. All these things are reasons why we have to aggressively treat blood pressure. There are some genetic considerations with some of the medications. We know that one of the beta blockers works better with African Americans, and we've shown that calcium channel blockers and diuretics have been shown to be more effective in African Americans. So there's some genetic considerations when people are prescribing those. So very important to do a head-to-toe assessment on your patient, assess for any contraindications to antihypertensive medications, and that would be what? That their blood pressure was too low at the time. Assess for conditions that could require caution in these drugs. So what might require caution, especially with a beta blocker? Think about it. The asthma or COPD, that's right. And we take the patient's blood pressure before we prescribe a medication, and we do it in the right way. And that's why this slide is here. We do it with their feet on the ground, their back supported, their arm nearly at the level of their heart, arm supported, and that's how we take a good blood pressure. So we want to educate patients about taking their medications routinely, not skipping doses, and checking their blood pressures at home with whatever type of device that they would like to use. We encourage people to keep a journal so we can see what their blood pressure is doing on a daily basis and even several times a day. If someone complains of feeling or having lots of orthostatic hypotension in the morning or low blood pressure in the morning, we want them to take their blood pressure in the morning. Maybe it's very low in the morning and gets higher throughout the day. And if that's the case, then we can adjust their medications accordingly. We, as I mentioned before, we don't want them to stop their beta blockers or any of these medications abruptly because it could result in a hypertensive crisis or stroke. Their blood pressure could go very high immediately if they stop their medications. We want to always with these, and I've talked before about that with this many times, is to talk to people about weight reduction, stress reduction, exercise, decreased alcohol intake, those things that could modify their blood pressure without them having to take medication. And we would find that most of the time people are able to come off their medications or at lower doses if they can embrace these lifestyle changes. If someone is taking these medications, of course, we're going to want to know if they're having episodes of dizziness. We want to encourage them to change their position slowly when standing up or getting up from a seated position. And we want to hear if they're having any difficulties with shortness of breath, swelling in their feet, if they are taking an ACE inhibitor, are they having a cough? Any of these things, well, these things are really symptoms of what? Of poor cardiac function. And so we want to know if these are happening because it could be that their hypertension has gotten to the point where it's affected their cardiac function. These are just some other things I'll let you read through these to consider when someone's on antihypertensive medicines. But I will tell you that people do need a great deal of nursing support when they're started on these medications because they come in frequently to have their blood pressure checked in order to make adjustments to medications. There are some side effects that can be bothersome, and we want to know about that so that we can talk them through it and coach them through how to manage those side effects so they can remain on their antihypertensives. We talked about these nursing implications before about anything that's a vasodilator and how it could be contraindicated when someone's already taking a vasodilator. And we talked about the lifestyle changes. So monitoring these patients and getting them to their goal blood pressure so that their blood pressure is within an acceptable range that will keep them safe in the long term. So that really concludes the antihypertensive medication lecture. I know that there's a lot of medication, so you may want to listen to certain parts of it. Be sure that you do the reading and associated exercises, and we'll talk about some of the things you might have questions about this in class. Okay,